I think the problem with Sinclair is that because a woman doesn't show up with a red swollen breast and a fever, it's not a problem. Just look at all the evidence. So I take all these out, and there's chronic inflammation on every single pathology specimen. 29% in our study that we published have bacterial contamination. So you have chronic inflammation, you have bacterial colonization on a foreign body underneath the breast, on top of your heart.
Sounds like a recipe for disaster. It's not great. Let's be honest. It's not great. Why isn't this explained to a patient as part of getting implants?
Oh.
What are the ethical obligations there, and why hasn't that been addressed?
Yeah, so I try to think of it this way. Implants aren't going away, but the patients should, and the provider should, have the best information to help them make an informed decision. Anybody can make an informed decision once they have all the information. They can make their choices. So I don't think anybody should ever be told these are lifetime devices, because they're not. They fail, they rupture, they leak. If it's saline, it deflates. If it's silicone, it can rupture. Even though it's cohesive in nature, meaning it's more like jello rather than syrup, it can still migrate within the capsule. And all those things are really, for lack of a better word, poorly understood. The studies done during the implant crisis, during the moratorium, I would say were limited because of the tools used at the time. PCR analysis was not being used at the time routinely. I use it commercially and have since 2019. I don't want to underscore it, but everybody knows when you put a device in, you create an environment for inflammation. So that should be understood. And how you genetically detoxify, we have the Genome Project. We shouldn't act like it doesn't exist. And whole body sequencing or whole genome sequencing is becoming less and less expensive, certainly with artificial intelligence and its growth. All these costs that used to be extravagant for testing for some of these things are going to go down. So we already know that our patients have multiple problems in detox genetically. Further sets them up for a problem. If you look at the exposures, I know you're very keen on looking at environmental toxins, we see a lot of DDA, DDP, DDE, TPH, glyphosates, phthalates. I've seen a host of heavy metals, probably more so than any plastic surgeon around the world. We've looked at carefully and audited our patients' environmental toxin exposure, which is very high relative to the reference ranges or the norms. Now, why is that? Well, genetically, they already don't detox well. And they have a device in place that furthers a distraction to their immunity. You can see how the balance will get off much more quickly in those patients.
So given all of that, what do you wish was being said in that very first consult? I would love to see a summary of what you just shared, hey, this is important, this, or you have informed consent. But is there any other piece that you think must be said in that initial consult in order to have real informed consent?
Right. I think overall, I would do it the same way that actually I was taught. Any device can get infected, right? It's not meant to be a lifetime device. And if it's a silicone device, it can rupture. And because it's silicone, not saline, it's not going to deflate. It's going to potentially migrate and affect the other tissues. It's not supposed to be as big of an issue because it's cohesive and more like jello rather than syrup. But still, if a woman with breast cancer reconstruction came in with a ruptured implant, I of course would get her on the schedule to get it taken care of, because you don't leave broken things in people. A broken knee or a broken hip implant isn't left in someone. You wouldn't be able to walk. So we shouldn't be leaving broken devices in anybody for any amount of time that's unwarranted. So devices are not going to go away, but it would be great to be able to check someone's genetics and understand their toxicity burden and gut health and hormone balance before you ever put one in somebody.
So when you say things like, if that device ruptures and then, the material migrates and could affect the tissue, affect sounds very benign. What specifically do you mean by that?
Yeah, you'll get local inflammation at the site. So you'll see those cells on pathology, histiocytes and giant cells. Those are the cells typically you see of chronic inflammation. With or without a rupture, you'll see those. And then when people have a rupture and leach the components of the shell into the tissues, it gets picked up by the lymph, and then they'll see it in the lymph nodes. So I always get folks bringing scans or messaging us, hey, I have silicone in my lymph nodes. How can you get that out? What can I do? And for me personally, is you don't ever go tooling around someone's axilla trying to pluck lymph nodes out, because that'll create lymphedema. So we get all of it cleaned out, and that's why I'm a proponent of capsulectomy. We didn't talk about that. So I do a capsulectomy on every patient. I don't ever leave caps on anybody. 29% are infected, so I can't guess who's going to have that problem. So I always take it all out. Obviously, I'm very efficient. I've done several thousand of these and over 10,000 operations over almost 30 years of operating now. It's not dangerous. It's a safe procedure to do in competent hands. The way to move forward for explant is, in my opinion, is to do a capsulectomy, send everything off to get it tested, let patients heal up, recover them properly. We have a very specific methodology called SHARP. We do pre-op preparation with all the testing we described previously. We have ultrasound-guided nerve blocks, intraoperative nerve blocks, Most of my patients do not need or require any narcotic that's IV afterwards. They may need a little bit of oral, which is fine. And they come to the office the next day for treatment. We have hyperbaric oxygen, lymphatic massage from New Zealand with Flopresso. We have the human regenerator, one of 3 clinics in North America with one of those to help with parasympathetic activation, and red light therapy, of course, and NanoV therapy. So the things that can help us move along quickly from the biohacking and the longevity work that's being done, we try to employ them when we can to blend it all together to give patients really good outcome.
Yeah, I think that's what's really special about what you do, because it's such a hard road for women to, first of all, understand what's happening to their bodies. And second of all, gear up to actually do something about it, because another surgery is scary, especially when you don't feel good. And then so many of them feel like they've gotten left for dead afterwards because a surgeon cuts and then the surgeon is done. And you have a really different approach. Simplify what you just shared, because those are a lot of tools to throw at somebody very quickly. What is your philosophy that actually gets somebody from being sick to all the way well post-explant?
Yeah, first, I think the easiest thing is to focus on what you can without coming to see me or talking to me. Either learn from what we've put out online on YouTube or through books. And then we focus on prioritizing sleep and anti-inflammatory diet, so cutting out gluten and dairy and seed oils, taking in, as highly filtered clean water as possible, cutting out anything that has garbage in it. You can't drink energy drinks or other shit, basically. And then from a supplementation standpoint, we're very, very concise and clear on what we want. We use liposomal supplements, so they're liquid. And the point that I make to my patients is the reason I do that is your absorption is not something that I need to predict. I would rather it be liquid and liposomal and absorbed as quickly, as high in the GI tract as possible, so you get it. And then I already know you probably have problems with constipation or diarrhea based on your exposures. So it's something that from a absorptive standpoint, I ramp up protein for healing, because we need amino acids and proteins to heal. We don't need a bunch of carbs and fats. That's not really going to help us heal. We need rest. We need restorative sleep, and then all the magic will happen at night, because that's when you heal. You don't heal during the day when you're up and about doing your thing. I know your genetic profile usually when I hear you in an interview, but we confirm specific things to help them understand their genetic profile. So if you have a poor vitamin D pathway, that's going to lend itself to osteopenia and osteoporosis for a woman, which you have to avoid. Most people have heard of MTHFR and all of its clever descriptions. 36% of the Caucasian population has an MTHFR problem. I do. That's not a new thing. An antioxidant pathway. So for cellular stress, we build up all these from the antioxidant pathways. We build up oxygen-free radicals, and they have to be metabolized. But if we have a poor pathway, we'll have more of that build up, and that'll contribute to more inflammation. And then finally, the thing that you and I both probably deal with a lot that we still struggle with is certain people have mold exposures or parasitic exposures. And those are by far the things I've had to learn the most about as a allopathic physician, and understanding this better, because it's poorly understood and contributes a lot to what my patients experience. So we look carefully at gut health, and we try to identify all of their environmental exposures pre-op, so that we're not reacting to problems post-op in terms of healing. So we try to help everybody get a proper foundation to begin with, and then help them over that year that we take care of them. And then afterwards, we get them into more of a maintenance program, depending on what they need.
First of all, thank you for providing the service. I'm serious. Somebody has to set a standard to help these women. I feel like they're getting left for dead.